The topic of this lecture will be the discussion of the nervous system in terms of pediatric medicine, beginning with the anatomophysiological peculiarities of the nervous system. Presenting your lecture information on the screen, and let's begin. Here we see in this chart the development of the central nervous system, beginning with the interuterine development stage. In the very beginning, about the 25 days interuterine period, we have the primary brain vesicle formation, about 50 days neuron proliferation, 100 migration, about 5 months of interuterine development, synaptogenesis beginning, which is going to continue on, or on and on. Then after this period, we'll have the beginning of the programmed cell death, apoptosis, synaptic reorganization, and the initial myelinization. Fetal movements, beginning with the 5 weeks and moving down, we have twitches, moves of arms and legs, 10 weeks moves head, breathing movements, obviously no inhalation into the lungs, opens jaws and yawns, sucks and swallows, 15 walking movements, sleep cycles, about 20-25 weeks. We have pain reactions, cry expressions, auditory reactions, habituation, blinking reflex at certainly after 25, visual fixation, developing after that time as well. Then, of course, we have the birth, and at birth, many things change with the child, and of course, with the rates of maturation of the brain. We have rapid synapse overproduction, neuropeptide maturation, major catecholamine surges at birth, stimulates arousal and increases electrical activity. And of course, as the child grows, we will have more signs of maturation and development. And let's move on from this chart. Let's take a look at the most important aspects of the central nervous system development of children. So we have here at the 2 weeks, neural plate forms from the ectoderm and the neural tube completed by day 26-28 of interuterine development. 3-4 weeks, we have the actual hemispheres forming. We have the pons and the medulla development. 8 to 18 weeks, neuronal proliferation, up to 200,000 new neurons per minute. After 25th week, we have arborization, synaptogenesis, apoptosis, initial apoptosis beginning, neural connectivity, the axon dendrite connections, 30 weeks, and continuing on all throughout adolescence is the continuing of myelinization. The mature human brain will have about 10 billion neurons. Most are formed during the period of rapid proliferation of 8 to 18 weeks. Very little neurogenesis after birth. 70% of developing neurons will die by apoptosis during development. The initial factors of apoptosis, we have the BCL2 family, the APOP1, and the cysteine protease caspases. So the question that is probably on your minds is the importance of these periods, especially of periods of interuterine development, to pediatricians and general medical practitioners. The answer course, begins with the fact that at various stages of embryogenesis and fetogenesis, we can have factors that can damage the fetus, leading to the appearance of various degrees of birth defects and related organ trauma, which means that uh, if a factor that is damaging, we'll call that a teratogenic factor, which could be of various types from physical, chemical to biological. For example, radiation, various drugs that the mother is taking, or infectious diseases such as rubella, cytomegalovirus, for example. They can damage, if they occur in the parent, the mother, um, the pregnant woman, I should say, in the period of 8 to 18 weeks, then we can predict that we can have significant brain damage and the appearance of various related disorders after birth. And so the importance is that we can make certain predictions and therefore give certain recommendations based on that, and of course, our interpretations of the various prenatal analysis, ultrasound scans, etc. Let's move on and look at the anatomical and physiological specificities of the small child's neonate's brain. High vascularization of the brain, especially of the gray matter. Weak blood backflow from the brain. Toxic compounds can easily accumulate in the brain. Brain cell requires 22 times more oxygen. The amount of cerebral spinal fluid in the children's brain is less than an adult and slowly becomes more. The anatomic structure that is compounded of 5 parts is analogous to that of the adult. So while anatomically the brain looks the same, physiologically, functionally, it is quite different and much more demanding. Factors of development of the brain. The main structural functional part of the brain is the neuron. In newborn, the amount of mature brain cells which will become part of the brain structure is only about 25%. In 6 months, it is 66%, and in 1 year, it's 90 to 95%. If any factors affect the brain cells, the compensation is only possible before 18 months. So if we have traumas, hematomas, neurological diseases, acute neurological infections, then there is some ability of the child's brain to compensate the damage caused by them, but only in the period of up to 18 months. The process of normal development of the brain and growth of the brain is affected by feeding of the child, imprinting, and education. So again, these are all the basic parts. What would be the important clinical significance of these? Let's go back to this slide and examine some of these anatomo-physiological peculiarities in terms of their clinical significance. For instance, the weak blood flow from the brain that can lead to accumulation of toxic compounds as well as byproducts of metabolism. This leads to the fact that we can have a very quick development and very easy development of brain edema in small children, and development of the possibility of the hydrocephalus syndrome. Factors of development, we've mentioned them, and we've mentioned about the possibility of regeneration up to the age of 18 months. But also at the same time, this implies that the brain is growing quite quickly, and if the brain does not receive its nutrition, its oxygen, and its energy due to insufficient feeding, improper nutrition, or perhaps due to various other problems, such as the deficiency of main metabolic hormones, such as thyroxine. This may lead to the underdevelopment of the brain, which may become irreversible even if the feeding can be corrected or the deficient thyroid hormone can be replaced. As mentioned previously, the cells undergo apoptosis, and the apoptosis is initiated in the cells that do not manage to create any synaptic contacts. Let's move on to the examination of the blood-brain barrier. Now, one of the debates that's still going on is over an hypothesis that the blood-brain barrier of infants is what is called leaky, right? That it's not the same as that of adults, and it allows a higher level of transition to the brain from the plasma. Tight junction in mature blood-brain barrier form a true zone of occludence. We agree that permeability of the macromolecules is the same as in adults, so the question is only becoming to the micromolecules. Blood-brain barrier has both static and dynamic properties. Astrocyte feet have lots of control of what goes in and what goes out. Impermeable to ions, proteins, and osmolar agents. Osmotic but not oncotic gradients are critical to water movement through the aquaporin channels. Antenatal risk factors. Various chronic diseases of the mother, intrauterine infections, genetic defects. Alcohol, smoking. Professional risks such as physical strain, vibration, exogenous, radiation, chemicals, and drugs, gynecological anomalies, diseases of the mother, Rh factor incompatibility, prolonged pregnancy, or the possibility of twins or hypertrophy. Semiotics. So what do we have as presentation of these disorders? We have hydrocephalus, possibility, microcephaly, Down syndrome, cerebral palsy, spasms, convulsions, seizures, and meningitis. So let's take a look at each of these. Hydrocephalus is a condition in which an accumulation of cerebrospinal fluid occurs within the brain. This typically causes increased pressure inside the skull. In babies, it may be seen as a rapid increase in head size. Other symptoms may include vomiting, sleepiness, seizures, and downward pointing of the eyes. Hydrocephalus can occur due to the birth defects or be acquired later in life. Associated birth defects include neural tube defects. Other causes include meningitis, brain tumors, traumatic brain injury, intraventricular hemorrhage, subarachnoid hemorrhage. The four types of hydrocephalus are communicating, non-communicating, ex voco, and normal pressure. Let's take a look at how it presents itself clinically. As you can see, the enlargement of the head and the skull part, the brain part of the head, can be from small enlargement to an extremely significant enlargement. Right, as the pressure rises and the skull sutures are not completely closed, this leads to the spreading of the skull bones and enlargement of the head itself. Next, let's take a look at microcephaly. Microcephaly is a condition in which the brain does not develop properly, resulting in a shorter than normal head. It may be present at birth or develop in the first few years of life. People with this disorder have an intellectual disability, poor motor functions, poor speech, abnormal facial features, seizures, nanism. It is caused by a disruption to the genetic processes that form the brain early in pregnancy. So, like I mentioned previously, various teratogenic factors, depending on the stage of pregnancy, this, the effects of teratogenic factors can be different. Microcephaly typically is the result of teratogenic factors acting in the first 75 days of pregnancy, meaning that it's a problem called embryopathy, the embryological period. Many genetic syndromes can result in microcephaly, including chromosomal and sacral gene conditions, though almost always in combination with other symptoms. External toxins to the embryo, such as alcohol during pregnancy, vertically transmitted infections, are such teratogenic factors that can result in the development of microcephaly. Microcephaly serves as an important neurological indication or a warning sign, but not uniformly exists in its definition, which means that it's more of a syndrome associated with problems rather than its own diagnosis. Here is the clinical presentation of microcephaly. As you can see, we have a normal head size versus microcephalic head size. We have the skull part of the head being much smaller in circumference. Down syndrome. Down syndrome, also known as 21 chromosome trisomy in most cases, although there are instances of other situations that can lead to symptoms extremely similar to Down syndrome and can indeed be referred as Down syndrome, such as certain levels of crossing over between the 18th chromosome. But for the most part, we shall consider it a 21 trisomy. It's a genetic disorder caused by the presence of all or part of the third copy of the chromosome 21, usually associated with physical growth delay, mild to moderate intellectual disability, and characteristic facial features. The average IQ of a young adult with Down syndrome is about 50, equivalent to the mental ability of an 8 or 9-year-old child, but this can vary widely. The parents of the affected individual are usually genetically normal. Probability increases from less than 0.1% in a 20-year-old mother to 3% in those of age 45. The extra chromosome is believed to occur by chance, with no known behavioral activity or environmental factors that change the probability. So, unlike the previous condition, this is not connected to teratogenic factors, which is not to say that they have no influence, it's just that we have not found any connection to them. Down syndrome can be identified during pregnancy by prenatal screening, followed by diagnostic tests after birth by direct observation of the genetic testing. Clinically presentation, the phenotypical signs of Down syndrome we can observe on the child's facial features, which are typical, certain type of eyes being more narrow, called mongoloid. We can have the formation of various other stigmas of dysembryogenesis on the face. Typically, we see these signs in the child. Cerebral palsy. Cerebral palsy is a group of permanent movement disorders that appears in early childhood. The symptoms include poor coordination, stiff muscles, weak muscles, and tremors. There may be problems with sensation, vision, hearing, swallowing, and speaking. Often babies with cerebral palsy do not roll over, sit, crawl, or walk as early as other children of their age. Other symptoms include seizures and problems with thinking or reasoning in one-third of the people with cerebral palsy. Cerebral palsy is caused by abnormal development or damage to the parts of the brain that control movement, balance, and posture. Most often, the problems occur during pregnancy, during childbirth, or shortly after. Risk factors include preterm birth, being a twin, certain infections during pregnancy, such as toxoplasmosis or rubella, so teratogenic factors, exposure to methyl mercury during pregnancy, chemical teratogen, difficult delivery, birth trauma, especially head trauma during delivery or during the first 3 years of life. About 2% of cases are believed to be due to inherited genetic syndromes. Here's the clinical presentation with phenotypical signs. Mostly, we will see um, problems with the eyesight, with the tonus of muscles of legs and arms, presenting inability to walk in children. Let's move on to the spasms, convulsions, and seizures. Here we can see generalized and local convulsions. The first we can observe is the tonic clonic convulsions. We have the tonic phase, the hypertonus, or sometimes referred to as the classical, as you can observe below, opisthotonus, right? Similar to the hypertonus that we see with such infectious disease as Clostridia tetani. So we got the tonic phase, the muscles all tense, hypertonus, flexors of upper extremities, extensors of the lower, the back, the head, as well as hypertonus and spasm of the diaphragm, inability to breathe, and possibly cardiac arrest. In the clonic phase, we have tremors or shaking of the child, usually beginning from top down, beginning with the mimic musculature of the face, and then the arms, and finally the legs. In this case, can also cause respiratory problems, appearance of foam from the lips. And it's quite important to remember that when the child is going through this phase, do not hold him down, as this may cause fractures of his extremities or any place that you're holding him down. Do not put anything into the mouth of the child, especially if it's a newborn child, as you may traumatize the soon-to-be first teeth. Here are some more examples of the tonic opisthotonus. Similar presentation would also be with this kind of increased tonus. And here we have localized convulsions, localized seizures, local seizures or spasms, where we have the carpal spasm of the hand. Right, here's another picture. And the similar situation occurs with the foot, where we have a pedal spasm and the appearance of what's called equinus foot. And this is the larynx, the vocal cord, as the child may manifest laryngeal spasm as an isolated convulsion. Of course, laryngeal spasm can also accompany tonico-clonic generalized convulsions as well. evaluation of the functional state of the nervous system. So the examples are places where they actually do these evaluations, like in the military. Um, Obviously, it's very important there. So one of the tests is called the balance and coordination test, or the Romberg's test, where the person stands with his feet aligned together, eyes closed, and arms straight forward. The person is supposed to maintain the balance. If he starts shaking, and the possibilities are forward to back or left to right, or falling down, obviously this implies that we have a problem with the balance and coordination system of the nervous system. And of course, we can make more advanced testing, as you can see in the lower right hand corner. We can have the patient put one foot in front of the other as a second degree test, standing on one leg while the other one is touching his sole to his knee. And the last one is the swallow position. The swallow position, this can cause shakiness in even um, healthy people that do not have excellent balance. Of course, this is also a good test to check if somebody is inebriated. Furthermore, to evaluate the function of the central nervous system, we also have these coordination tests, such as the finger-nose test and the heel-shin test. Finger-nose test is performed in several ways for small children. You can also have the finger-finger test between the doctor and the patient, or even the finger-finger test for the patient themselves as they attempt to touch their own fingers. The finger-nose test can be given in small children while their eyes remain open, see if they can touch the nose, or the more classical presentation as the person is standing up straight or sitting. Eyes are closed, facing forward, arms are in a T shape to the sides on the horizontal, and one arm at a time, moving the finger directly to the nose. The movement has to be fluid, fast, but not too fast. And with the patient lying supine, ask him to place his heel on the opposite knee and then slide his heel up and down the shin between knee and the ankle, and this would be the heel-shin test. Other neurological signs to watch out for can include the Grapha sign. The Grapha sign, you can see that the iris of the eyes becomes separated from the upper eyelid, allowing us to see the sclera above the iris. Now, this can come as a normal, the child is simply looking, or you can have the child try to focus his eyesight down. So obviously, if this is a newborn child, you're not going to be successful in getting the child to focus his eyesight, right? Which means that the examination would have to be more at random while monitoring the eyes of the child as they're moving and seeing if there's a um, sufficient discoordination between the upper part of the iris and the upper eyelid. And if the child has the ability to sort of focus on something, so get a bright toy and start showing, move down, and the upper eyelid will separate from the upper part of the iris. Another important sign is the Flatow sign. It could be interpreted as a sign of meningitis, or for the most part, since all meningeal signs are basically signs of intracranial hypertension, just like the Grapha sign, can be used for multiple instances, including intracranial hemorrhages and hydrocephalic syndrome as well. Flatow sign presents as mydriasis or pupillary constriction in response to neck flexion assisted, if necessary, in meningitis. Etiology is unclear, but stretching of medulla and involvement of the meningeal sheath of spinal nerve radices. might be possible causes. So we have the dilatation of the pupil in a passive flexure of the head forward. We should do this quickly. Right? That's a typical meningeal sign, which can be checked in neonates and newborn children, for which other signs would be uncheckable, but also would be positive in most cases of intracranial hypertension. Here are some more of the classical meningeal signs associated and the presentation of the meningeal syndrome. So the symptoms of the meningeal syndrome itself include things such as headache, cephalgia syndrome, nausea and vomiting, dyspeptic syndrome, protrusion of frontal fontanelle in small children, neonates that actually have a frontal fontanelle still present, general hyperesthesia, meningeal position, rigidity of occipital muscles. The specific meningeal signs include the Kernig sign, the Brudzinski's upper, middle, lower, and zygomatic sign, and the Lasega sign. Now, unfortunately, all of these signs can only be checked in children after approximately the age of 4 months, as before this time, they may be considered physiological because of the hypertonus of lower and upper extremities that we observe in small children, which means at age below 4 months, they cannot be considered conclusive proof of meningitis. However, we do have the early neonatological signs, which I mentioned previously. We have the Flatau sign and the Lesage sign. The Lasega sign is shown here. The doctor attempts to lift the straight leg upwards, but cannot lift it straight more than 30 degrees from the bed. The Lesage sign is here on the bottom, where we're lifting up a baby under the arms, and if it's positive, we will have a flexure of the legs being bent in their knee and elbow joints. Well, they're always bent in their knee joints, um, bent in their hip joints, and the leg will become completely pressed against the abdomen. Only in that case will we have the positive Lesage sign. The Kernig sign, uh, when we flex the child's leg in its knee and hip joint, we're unable to straighten it in the knee joint. The Brudzinski sign mostly involved with various triggers to stimulate the bending of the involuntary bending of the legs in their hip and knee joints. Meningeal position of an infant and an older child can be observed. And just for your information, the endemic region for meningitis is shown on this map from the data from the World Health Organization. Evaluation of the meningitis and other conditions that may lead to increased cerebrospinal fluid pressure, possibly various hematomas, hemorrhages in the brain, can be done with the aid of a cerebrospinal fluid punction and analysis of the fluid. Here is a chart discussing the possibilities and the changes from normal of the cerebrospinal fluid that can lead to the preliminary diagnosis based on the conclusion of the cerebrospinal fluid findings. So various parameters, including color, transparency, pressure, frequency of drop cytosis, the actual formula for the leukocytes, proteins, PAM-D reaction, also not mentioned in this particular slide, but will be shown later, is the glucose concentrations and the condition after the punction, where we have the normal data presented here on the slide. The changes that will happen for the syndrome of meningism, mostly involving the pressure being higher than normal, and hence giving us a higher frequency of drops, everything else being the same, except the way the person feels after the puncture. He feels better, while in the case of a healthy person, he will feel much worse. Purulent meningitis, clearly we have changes to all parameters of the cerebrospinal fluid, including the color and the transparency, the pressure being very high, although the viscosity is so high that the drip rate is actually very low, high level of cells and proteins, and only insignificant improvement after the function, and various kinds of serous meningitis, where we have mostly increased pressure and frequency of drip rate, but to differentiate it from meningism, we can see that the level of cytosis and proteins is much higher. And in this chart, we can see the difference also as it pertains to the tuberculosis meningitis. So viral serous, bacterial meningitis, and tuberculosis. You can take a look that the tuberculosis meningitis is similar to both bacterial and viral. The amount of cells are very high, much higher than viral, but the cell types are not neutrophils, but mostly lymphocytes. And one of the main differentiations also between the viral and the tuberculosis is the fact that the glucose is utilized by the bacteria in the cerebrospinal fluid and decreases, as opposed to the viral where it doesn't. Instrumental diagnostics. What do we have in terms of instrumental diagnostics for the nervous system? We have the MRI, magnetic resonance imaging, computer tomography, electroencephalography, neurosonography, Dopplerography of cerebral blood vessels, amongst others. So these are some of the more common methods that are used, and let's take a look at them. We have the MRI presenting a basically various slices of the person, right? In this case, we're looking at the brain, and we can get some very good quality imaging. Very good at distinguishing tissue. However, in case where we want a little bit more information, we can use MRI with contrast to get more details. For instance, if you want to take a look at just a certain part of the brain, like the hypophysis hypothalamic system. The negative aspects is that small children, well, the negative aspects that you have to lie still there, right? And which means that small children might not be able to lie still in general at all, or may become very scared or panicking to the typical noise that the machine makes, which means that in almost all cases, small children will have to get the MRI scanning with under general anesthesia, narcosis. Very, very small children, neonates, right, the ones that just born, we might actually use the machine without narcosis if we have the proper strapping equipment where the child can be strapped down to the machine, as in case of newborn children, right, the narcosis may be more harmful than simply strapping the child down. Similar situation with the computer tomography. The main difference is that this gives us some radiational load onto the child and gives a certain degree of better differentiation with certain tissues. But in some cases, to get soft tissue differentiation, we might want to consider using low doses of radiation for the computer tomography. But the general rules and drawbacks are pretty much identical. So if the question arises, which procedure should I use? The first answer is, well, which one do we have at the hospital? If we have both, then we can talk about the certain advantages of using one or the other in certain situations. The next one is the EEG, electroencephalography. So this method is non-invasive. It doesn't actually require any kind of specific preparations, can be put onto any child. at any age. Usually it does not make the child scared or frightened usually. You never know with children what they're afraid of, but in general. And we can get readings of various wavelengths, which in a lot of senses helps us evaluate things like convulsions, seizures, and the possibility of epilepsy, as well as diagnosing various sleeping patterns and sleeping disorders, amongst other things as well. Neurosonography, this is a very interesting procedure. It's an ultrasound of the brain. And this procedure can only be performed in very, very small children, neonates, and maybe slightly older infants of the first few months of life. Why? Because only to those groups can we get ultrasound access to the brain. Because in older children, the brain is covered, of course, by the bones of the skull, and we have no way of penetrating them. But in very small children, they have opened the large fontanelle, and if it's sufficient size, we can use that as an access point for the ultrasound monitor to get a picture of the brain, which means that we can get a very fast procedure that we can do fairly quickly without having to put the child under narcosis or special straps, which is good. Although in some situations, the MRI and computer tomography would be more efficient, especially in finding small defects, right? Neurosonography is good at finding any large defects and deviations, large hematomas, tumors, but if the defects are very small, it would be difficult, if not impossible, to find them in this procedure, but it is non-invasive. It can actually be even used as a screening tool in certain situations, like hydrocephalic syndrome determination, etc. So here we can see presentation of normal ultrasound and abnormal ultrasound in a child. Here we can see the expansion, and we can see the ventricles and the hydrocephalus syndrome in a preterm neonate. And Dopplerography. Here's another example of the Dopplerography. We can actually determine the blood vessels, the blood flow, right? And if there are any congenital abnormalities of the blood vessels, this can be a good method to diagnosing them, amongst other things as well. That's all. Thank you.